Garmin just told me I was stressed.
Hmm?
My Garmin tells me when I'm stressed, and it just
Really?
came up saying, you need to relax. So we just introduce ourselves.
Do we? Okay. Do you want to alternate introducing, or what do you want to do?
If you could introduce Tessa, because she's my colleague, and
You want me to introduce? Okay. It's the University of Stirling. Cool. Are you from Stirling?
near Sterling.
My wife's family's from Glasgow. So we're going to go meet them and hang out with them. Oh, it's... Love it. We got to go to a Celtic match last time this year. But they're away tomorrow, so we're going to go watch them. Yeah.
Hello? Can everyone hear?
Hello? All right, good afternoon, everyone. It's I think this is the last session, Friday afternoon. Thanks so much, everybody, for coming. I'm Stu Skinner. I'm an infection doc at Regina, Saskatchewan, Canada.
And I'm Hannah Carver. I'm a lecturer in substance use at University of Stirling. So we've got 3 speakers today, and we've got about half an hour at the end for discussion and questions. So I'm going to introduce our first speaker, who's Rose Schmidt, who has a Master's in Public Health and is currently a PhD candidate at the Dalla Lana School of Public Health at the University of Toronto. Her mixed methods research focuses on harm reduction and trauma-informed approaches to perinatal substance use. She addresses gender-based determinants of health inequality and integrates social epidemiological methodology into applied policy research.
No, you don't have to look at my LinkedIn bio. Okay. Hi everyone. Thanks for sticking it out and not going home yet. So I want to start by acknowledging that most of my presentation, it's based around this paper that came out this summer called COVID-19 and the Opportunity for Gender-Responsive Virtual and Remote Substance Use Treatment and Harm Reduction Services. And I want to thank my co-authors, particularly Dr. Carol Strike, Melissa Perry, and Nat Kaminsky, as well as my former mentors, Dr. Nancy Poole and Lorraine Greaves, who have informed a lot of my thinking about gender, as well as all of the members of community advisory boards that have worked with me over the years. Because without them, I'd know nothing. And I have to say that my doctoral work is funded by the Canadian Social Sciences Humanity Research Council and a Connet Fellowship for Public Impact, but I don't have any other conflicts of interest. So I'm going to talk a little bit about what is gender and what are gender-responsive services with a little example. And then talk about sort of this unique time that we've been given in COVID-19 and the opportunity for online and remote services. And talk about some of the limitations and things we should think about going forward. So what is gender? We often in science like to split gender and sex into sort of 2 concepts, gender being the sort of the social roles, relations, behaviors, expressions, and the identities that are associated with being man or a woman or a non-binary person or a boy or a girl. It's a really complex thing and it changes over time. And it's related to, as I said, sort of the roles and the behaviors and the normative expectations, but also distribution of resources and power and institutional laws and practices. Gender identity, I'm going to use to describe what people feel inside is their gender. Transgender being someone who their gender identity isn't what they were assigned at birth. And I use the term gender diverse to encapsulate transgender people, two-spirit people, non-binary, genderqueer, gender fluid, et cetera, because that would take up my entire 20 minutes, but want to acknowledge that I do mean that when I say gender diversity. Sex, on the other hand, is mostly is often thought about as a biological attribute, so things like chromosomes, gene expressions, reproductive organs, sexual anatomy, and we often think about sex and gender as a binary, man-woman, male-female, but there is considerable diversity, and I need to say this sort of as I go through, despite the fact that I hold gender as a concept that I'm going to be talking about, between groups and individuals on how both gender is expressed and experienced, and how these sort of biological attributes that comprise sex exist. Okay, so that being said, why should we consider gender in substance use services? Well, gender impacts people's access, retention, and experience with services. Remember, it's the roles, it's the relationships, it's the distribution of power, and all of those things impact the way someone can or cannot interact with a service. Most of the time when we don't consider gender, we think we're doing something that's gender neutral, but quite often that's actually reproducing power structures and harmful gender norms within our society. So things that are gender neutral often best meet the needs of the people who have the most power in our society, which happens to be cisgendered men. So for decades, scholars and activists have called on us as people who work in substance use to consider gender and to use this which can be considered across sort of this continuum, starting with gender unequal, which perpetuates inequalities, or gender blind. But I'd like to draw our attention to sort of this side of the spectrum, and those are the things that accommodate and transform gender. So gender-specific services are services like women's treatments programs, which acknowledge that there are differences between genders, and they accommodate them. So things like providing childcare at live-in treatments, for example. Gender transformative services, however, go like a step further than this. And this is something that I'm always aspirational to think about in my work, and I encourage everyone to be aspirational when they consider gender. To think about sort of the ways that we can transform these harmful gender roles, norms, and relations in our services. So not just accommodate them. So what the heck does that look like? So these are some pictures of an overdose, a supervised consumption room overdose prevention space in Vancouver. And it's as far as I know, the world's only women's only supervised consumption room, and it's called Sister Space. And you can see it is a very friendly, welcoming, beautiful space. There are comfy couches. It does not look like a medicalized facility in particularly. It looks like a nice little community health center, and they have tea and coffee, et cetera. And Sister Space was developed, it's run by Atira, which is a women's housing organization. That YouTube link takes you to a little documentary about Sister Space. And they started, Atira, the people who work at Atira, this women's housing group, started noticing that the people who lived in their housing were not using overdose prevention sites. They weren't going to Insight. They weren't going to use these needle exchange programs because they would have to often either line up with or wait after injecting with people who had caused them harm, wanted to cause them harm, or potentially could cause them harm. So they were just avoiding these spaces altogether. So there was quite a gendered inequity in those services. So this space is inclusive of trans women as well as non-binary femmes, and it's delivered based on gender-responsive principles. I'm going to skip what they are, but they're on their website. And it includes things like providing women with information and opportunities to improve their socioeconomic conditions. That's sort of the gender transformative part. In addition to addressing struggles with substance use and trauma, they develop programs that are relational and promote healthy relationships between their family members and their children, et cetera. So, great space, but that's a real space, right? It's in person. So, COVID-19, as my mother told me one time when I was having a very freaked out call with her at the beginning of COVID, that COVID has given us the opportunity for a new kind of time, and I think it's trying to think about, things that happen as opportunities or policy windows is something I like to try to do. So COVID-19 gave us something that we didn't want to do in substance use treatment for a really long time, substance use services, and that's do things remotely. Use telehealth, use apps, use Zoom conferencing, admit patients, titrate patients using telemedicine, providing carries as long as someone checked in on the phone, etc. So we now have sort of this, the door has been opened, Pandora's box is open, and as these services get developed, we have an opportunity to consider gender. So we don't have to just replicate the exact services that we have already. We can actually plan something that works for people. That wasn't to call out anyone in particular. So when we're considering gender, here are some things that I think we should think about. Okay, so thinking about providing violence-free spaces. So women and trans people often experience stigma, harassment, discrimination, physical violence, sexual exploitation, and victimization at in-person services. So as I said, research in Vancouver, this is sort of backing up at Atira, those observational things from the women at Atira, is that they often find that women will use alone and not use harm reduction services in order to avoid the risk of violence and discrimination. So while using alone provides people with more control, it does reduce your risk for overdose. Controlling violent and exploitive relationships among peers and partners can also influence how women and gender diverse people use drugs. So, you know, the term second on the needle, which increases people's risk of hepatitis and HIV. Using remote and virtual substance services, however, can contribute to giving a person a sense of empowerment and to use drugs safely. So it can help further, they can further assert their agency within potentially coercive and negative relationships. They can make decisions for themselves. They can also provide more private and confidential services. So people can access services from their homes, for example, if they have them, and avoid the risks associated with accessing in-person services. So the two most commonly cited barriers for why women don't access services is a lack of childcare and the very real fear of child welfare involvement and child apprehension. Research highlights that even within these gendered spaces, so even at Sister Space, this is what the study is from, they weren't reaching pregnant people and people who have children. There's still an inequity there. But by expanding virtual and remote services, we can provide more options for people to engage. And in ways that they don't have to, they can mitigate many of the issues related to childcare. If you can access services without having to put your child in care because you can access it at home, you no longer have that barrier. It also provides women and gender diverse people who are parents. It allows them to avoid the risk of being outed to child welfare agencies, and the added security of using phone or text or application-based interactions can foster agency among people to disclose whether or not they even have children. We need to think about including trans and non-binary people. Gender-based discrimination and trans misogyny are forms of oppression that are faced by trans women and trans feminine people. The discrimination can produce really specific harms and disproportionate related drug harms. For example, a lot of trans people will avoid accessing services or harm reduction spaces because they have a feeling that they need to pass as a gender in order to access it. So for example, the stigma and discrimination of someone who looks obviously transgendered may not want to go to a women-specific service. Additionally, there are very, very few specific trans services anywhere. I don't know of any trans-specific harm reduction services in the world. Often the small proportion of people who identify as transgender or the lack of demand for services is used as sort of an explanation for why we don't create them. But the use of digital options can really facilitate access as well as mitigate discomfort. Here's that one, right? Transform gender relations. We can consider really transforming how we use gender relations in our services. So in general, and this was mentioned if you were at the session upstairs about diversity earlier today, it was mentioned, women's drug use is often seen as socially less acceptable than men's. We're more stigmatized for our use. We feel judged. And because we've diverted from the socially acceptable feminine expectations. Feminist and gender theory scholars have highlighted how systems like substance use services can perpetuate harm and inequality by reproducing social norms and gender-based power relations. So concepts that are related to femininity, such as motherhood, reproduction, passivity, caregiving, they become embedded within institutions and form the way that systems and services are developed. So for example, there's really fascinating research looking at women's experiences in Vancouver of harm reduction services, and they often, they've identified that women feel that these are masculine spaces. And they don't like using them because they are expected to behave in certain gendered ways. They're expected to clean up after people. They're expected to be tidier than other people. They're expected to help men out of services, et cetera. So there are these gendered roles that become embedded within our services if we don't really think about it. And it reduces the likelihood that women will go to them. So providing alternatives to in-person harm reduction services can challenge normative notions of what that women and gender diverse people are passive recipients of care as well, and can facilitate autonomy around decision-making over overdose prevention. So for example, providing education on apps, for example, on how to inject drugs safely and independently, coupled with virtual overdose prevention services, can empower women and gender diverse people to use drugs outside of potentially coercive or power imbalance relationships. Okay, so those are 4 things. I've got a 5th one coming up, but I feel I'm going to take a little detour right now to show you some like real life. What does this look like? Those are kind of some high concepts things. So one of the things that has emerged because of the pandemic, it's happened informally a long time before this, and there's a citation on each of my slides. So some of the evidence I'm talking about, even like they're not my papers, they're just evidence that I'm talking about. So one of the things that is developed is spotting. So spotting is a novel harm reduction practice, and it's an overdose prevention or overdose risk management practice. And it works by connecting someone who uses drugs to a spotter. So like you're at the gym, can you spot this rep? It's the same kind of thing. So it's either a friend sort of informally, or it can be done through a telephone service or a mobile app. There's a few of those that exist. And it can empower women and gender diverse people to use in locations they deem safe and have a response that they have chosen. So, for example, this is a little video that was created by Kapud about spotting. And in this specific video, the woman asks for her neighbor to, calls her friend and says, I'm going to be using, can you check in with me in 15 minutes? If I don't respond, can you call my neighbor Sam? Sam has keys to my house. He'll come and knock on the door. So you can make the choice about whether or not, is the ambulance being called first? Where am I using? I'm using comfortably on my couch, right? I don't have to do it in a place that I don't find safe. And it has the potential to provide increased confidentiality, but we'll talk about that in a bit. Oh, and this may be particularly important for people who live in small and rural communities where there's a particular stigma related to drug use. Anyways, that's a tangent. I won't get there. So here's another example. This is again a COVID-19 example. It's something that happened out of necessity. So previously mentioned, appropriate and adequate childcare is a huge barrier to engage in treatment. So this is going to be about substance use treatment, not harm reduction particularly. And because childcare is particularly an issue when you're trying to access in-person or live-in treatment. And often people have to actually put their children into care and engage with the child welfare system in order to do so. However, when substance use treatment services are offered in the homes, women with children have to women with children, it's demonstrated really high retention rates and positive treatment outcomes, and as well as low rates of out-of-home placements. So this paper talks about a program in Boston that was a telemedicine program addressing substance use and prenatal care, which facilitated clients who had very complex lives to access services more easily without having to find transportation and childcare and deal with other logistical concerns. That's 3 minutes. Okay, I'll be quick. And it led to a hugely reduced no-show rate. It went from 34% of appointments being no-shows to 10% of appointments being no-shows. Scholars and activists have talked about the potentially liberatory potential for the internet and for trans people. It allows you to decide how you are presenting yourself to people and when you present yourself to people. It can prevent some of this idea of having to pass to be in services. So it can help by making trans and gender diverse people able to decide how they're seen by whom, when, and where. It can also bring together people from wide geographical areas. So the sort of that small percent, the 1 to 3% of the population that does identify as transgender, maybe doesn't justify a service in certain areas, but in virtual or remote ways, we could bring together larger groups of people to access culturally competent services. Skip that one. And then the final consideration I want you to think about is becoming trauma-informed. So on the first day, we heard a lot about choice in OAT, choice of administration, choice of what type of medication, et cetera. And choice is one thing I want you to consider, but I also think that, I'll step back a second. So there's really high rates of violence and traumatic events among experienced by women who use drugs and trans people who use drugs. So thinking about trauma-informed practice when developing all gender-based services is really critical. Trauma-informed practice is a systematic way of delivering services that aims to avoid re-traumatizing or traumatizing people and avoids replicating experiences of control and oppression. In addition to being developed with the awareness that trauma is very, very common and trauma impacts the way people act, it includes the principles of choice collaboration, safety and trustworthiness, and being strengths-based and skill building. So I have 1 minute left, so I'll get to some conclusions. But if you want me to talk about trauma-informed practice afterwards, I could give you a whole nother hour on that. So, and there's a lot of, okay, keep going. It's not without challenges. There's actually quite a lot of things to think about. There's a potential to increase digital inequity. Not everyone, and particularly probably the people who have the hardest time accessing services, will have a really hard time accessing these services. Reliable high-speed internet, having technology, having awareness of these services inequity could be exacerbated if we don't sort of acknowledge this. Surveillance and control. So criminal justice-related surveillance practices harm women and gender-diverse people who use drugs. And we have to make sure that the services we create do not further those harms, particularly when oppressive and discriminatory design intersects with other aspects such as race to magnify these issues of surveillance. So we need to make sure we're very careful about security and privacy regulations, and that this data that is created in these apps cannot make it into the hands of law enforcement and child welfare agencies. It's important to understand that if these aren't adequately resourced, they're likely going to exacerbate gender inequity. We know that much of caring work is done by women. Much of it is or underpaid. So if we are not adequately resourcing this, it can lead to additional unpaid labor. This doesn't do anything to address the actual underlying issues related to child apprehension and the policies there. So we do need to make adaptations to such policies to ensure that women and gender diverse people who care for children and who use drugs can access services without that fear. And finally, COVID-19 caused lots of isolation, and we have to make sure that this doesn't sort of further that isolation. So we have an opportunity to incorporate gender more fully into service design, implementation, and evaluation. I want you to make sure, if you are doing any of this work, to reflect on the ways that these virtual services could replicate environments that are hostile, unsupportive, stigmatizing, gender blind, and not trauma-informed, because if we aren't intentionally doing it, we will unintentionally do that. And while they will increase access and choice, they remove some of the challenges experienced by women and gender diverse people. It won't deal with a lot of the underlying structural vulnerability. So take-home messages. Gender, it's an important social determinant of health. COVID-19 and the recovery efforts have brought gender to the forefront of health and social policy. Virtual remote services can be designed in gender-specific and gender-transformative ways. And there's an opportunity for substance use services to become innovative, accessible, and effective for people who use drugs. Thanks.
That was great. Thanks. We've got a half an hour at the end, so we're just going to hold questions until the end after the three presenters. So I'll just introduce Professor Tessa Parks. So Tessa Parks is Professor of Substance Use and and Inclusion Health and co-director of the Salvation Army Center for Addiction Services and Research at Stirling University. She's a grant holder and deputy convener of the Drugs Research Networks Scotland with expertise in drugs and alcohol, harm reduction interventions, homelessness, and mental health. So it's all yours.
Thank you very much. Hello, everybody. Good afternoon. It's great. And I echo Rose's point about thanking for staying with us on a Friday afternoon. It's been a long conference. It's been absolutely brilliant. So thank you to the INHSU Conference Committee who've invited me to speak today about research in Scotland on these intersecting issues. So they gave me the topic of homelessness and mental health, which is what's in your programme, and I had a number of different titles. This is one that I've settled on. So I'm going to define my terms in a wee minute. I'll be drawing on studies that our own team have been involved in, as well as wider research in the field to provide an understanding of how we might approach these challenges, the intersecting challenges of homelessness, substance use, mental health, criminal justice and criminalisation, poverty and wider social inequalities. I really want to acknowledge Magdalena. I mean, I could talk about all the talks at the conference that have inspired me, but her point this morning, from this morning's plenary on community responses, but importantly, community-led responses. The research in the areas I'm presenting is generally focused on what services have to do differently and micro responses rather than multi-level responses. This is a key limitation of quite a lot of what I'm going to present today and something that we need collectively to change. So the structure of my presentation, I'm going to position myself briefly, talk about the interconnections regarding multiple exclusion homelessness. The committee wanted me to talk about barriers to care as well. Also, effective interventions, which I've divided into interventions about what should be delivered, and then how, because I think it's really important to talk about the hows as well. And then I finally have some selfish promotion of an example of what I consider to be a complex intervention, which is our Sharps intervention. And I have somebody in the audience who's going to probably heckle me on that. So very quickly, positioning myself, I've got experience as a mental health nurse and as a homelessness worker. That informs my practice. I worked in homeless hostels in London in the 1990s. I'm now have a wonderful job where I with Hannah, co-direct a centre that's funded by the Salvation Army Centre, which is a faith-based organisation in the UK, well, it's global. And they give us core funds to develop this university community partnership. And we do interdisciplinary research on substance use, homelessness, mental health, but also affected families and criminal justice in intersections as well. So all of the work that we do is relevant to the conversation I'm going to have with you this afternoon. In terms of conflicts of interest, we will be using our own team's work, and that's been funded by the Salvation Army, TSA, Scottish Government, NIHR, National Institutes for Health Research, and the Chief Scientist's Office. None of those funders influence our data collection, our interpretation, or our findings or ability to publish. I'm really honest about that. It's true. And that's not always the case. I want to also acknowledge, as we've all been asked to do and we all need to do, which is to acknowledge the contribution of people with lived and living experience, affected family members, our centre staff and funders. So I've used the term multiple exclusion homelessness. I'm going to just define some terms. So this term came into it's a UK term, and it came into being, other people might know differently, but this is what I went when I did a little bit of research on this, from a report called Tackling Homelessness and Exclusion, Understanding Complex Lives, which was a publication that was published in 2011, and had a number of multiple studies underneath it. And this one I'm going to talk about was from Fitzpatrick et al. At Heriot-Watt University, which is in Edinburgh. Colleagues of ours. So they did some work, and it included, the survey included Glasgow folks in services as well, which is partly why I wanted to use it today. So multiple exclusion homelessness was a term that came from this work, and it involves a strong, it's about having a strong overlap between experiences of more of homelessness and other support needs, as you can see up here. So nearly half of those surveyed, and I think it's about nearly 1,300 people, surveyed for the research experienced institutional care, substance use, and street activities such as begging, as well as homelessness. You can see that there. And there's a wee quote that I've used. For some people, homelessness is not just a housing issue, not surprise to you people in the room, I'm sure, but something that's inextricably linked with complex and chaotic life experiences, mental health problems, drug and alcohol dependencies, street culture activities, and institutional experiences. These are often closely linked with the more extreme experiences of homelessness. Traumatic childhood histories such as abuse and neglect are part of most street homeless people's life histories, as I'm sure many of you are aware. In adulthood, the incidence of self-harm and suicide attempts is also notable. Substance use can be a way of coping with previous trauma by blocking out disturbing memories and emotions. And there's a lot of work around mental health also being a form of coping, as well as a symptom of these issues. While a focus on adverse childhood experiences can, of course, be really helpful in understanding these experiences, it's important not to deprioritize the contextual factors such as housing and poverty and the systemic and structural underpinnings of many of these problems. So Hard Edges Scotland was a report which is only a couple of years old now, also by Bramley and colleagues at Heriot-Watt University. They use the term severe and multiple disadvantage and define this as the experience of homelessness, substance use, criminal justice involvement or criminalisation, but they also recognise the importance of mental health problems, challenges and domestic violence, which given Rose's introduction comments there with that talk, it's a very powerful reminder that we mustn't forget the experiences of violence. Those who experience severe and multiple disadvantage will likely be those that are most at risk of a range of negative outcomes in relation to ill health, death, early death, poverty, lack of opportunities. And we heard from Andy Macaulay and others at the beginning of the conference around it's not just those issues of social determinants of health, but it's the hope and aspiration that goes along, or the lack of hope and aspiration as well, that we need to be speaking about. In the UK, people from this group are likely to die extremely prematurely. So for women, aged 37 years, and for men, 42 years. So while the Hard Edges report actually talk about the highest dangers being for young and white men, it's important to consider other groups that are likely to experience even greater harm as when they experience these issues. For example, women and those that identify as LGBT+, and who commonly face even greater problems, additional intense stigma, and find it difficult to access services, as Rose was just speaking about. Considering their needs and unique challenges is vital. The issues are also clearly cyclical and interconnected, and Suzanne Fitzpatrick's work and her colleagues at Heriot-Watt show us that in terms of life pathways, multiple exclusion homelessness is preceded by adverse livelihood experiences like violence and trauma and institutional involvement, and poor mental health and substance use are ways of managing that. Sorry, I'm behind on my slides there. I haven't got time to go into theories today, but as a social scientist, I think it's really important just to make a plug here for the importance of critical theory to ensure we don't get into victim blaming. That hasn't happened at this conference. I'm not being in any sessions, but it can happen. It does happen, and we need to call it out when it does. We need to challenge the causes of the social suffering that's endemic in the issues that I'm speaking about here today. And obviously that was mentioned at the beginning of the conference as well. People are part of networks, communities, they have families, friends, and the structural elements within multiple exclusion homelessness must be acknowledged and addressed as part of our community and service responses. There's an amazing amount of research now in this field, and I'm only going to talk about 2 studies, but I've put the full reference up here so you can have a look at it. The slides are available for people afterwards. So this was a study, a systematic review and meta-analysis. As you can see, homelessness, unstable housing, and the risk of HIV and hepatitis C virus acquisition amongst people who inject drugs. So it synthesized 37 studies from 16 countries, including North America, Europe, Australia, East Africa, and Asia, which is good because quite often we don't have enough spread in these systematic review and meta-analyses. The key finding was that recent homelessness or unstable housing was associated with increased risk of acquiring HIV and hepatitis C among people who inject drugs compared to those who are not homeless and unstably housed. Probably not a big surprise, but a wealth of data. And importantly, their recommendation was to develop interventions that simultaneously address these issues with this population. And then closer to home, Emily Tweed's work, which was from Glasgow University, that's really just been published, and their interpretation of their findings, which looked at, this was a cohort retrospective study looking at a population register of adults resident in Glasgow using administrative data sets from homelessness, criminal justice services, community pharmacists and clinical psychosis registries. The data was between 2010 and 2014. Again, very complex piece of work. I know Emily, so I know how many years it took her just to get access to these data. So please use the work because it's really, really important. Their interpretation was that the co-occurrence of at least 2 of these experiences, homelessness, opioid dependence, justice involvement, or psychosis, is associated with very high rates of premature mortality, particularly from avoidable causes of death, including non-communicable disease. Avoidable premature mortality was highest amongst those with multiple exposures. So yeah, not a big surprise. But again, very different methods, very close to home for here in Glasgow, but similar recommendations, similar pointers to what we need to do. So what about the barriers to care? Again, I could go on for hours about this. People with complex needs are at serious risk of falling through the many, many cracks of which we've heard about today, yesterday, and the day before, whichever day that was, Wednesday, Thursday, Friday. Yeah. So, I mean, we've Dame Carol Black's talk, but yeah, we've got lack of appropriate services for this group prior to the austerity cuts that we experienced in the UK, 2017, 16, 17, and then COVID-related closures that Rose has also been mentioning. So things were difficult before, then austerity, then COVID. There are some silver linings around COVID, which I'm going to come to as well. There's significant challenges for this population around dominance of abstinence-based treatment models. Now, abstinence-based treatment models should be available, absolutely. The choice is so important, but there is a dominance of this, particularly within housing-related services. There are frequent tensions between abstinence and harm reduction in housing settings that researchers like Bernie Pauley, a close colleague of ours, has written about passionately. There's a lack of alcohol harm reduction services that's endemic in the UK. There's also a crisis of basic harm. There's also a crisis of general primary care for this group of people, let alone specialist primary care for people who are homeless that is usually better placed, like the work in Edinburgh and Glasgow that specifically offers primary care to people who are homeless. In terms of service environments, got there in the end, they generally can be very unwelcoming, non-psychologically or trauma-informed, badly maintained, just reinforcing the stigma that we've been hearing about so much. Quite often we've heard quite a lot about this as well in relation to opioid agonist therapy, restrictive, complex, and sometimes I put often punitive access arrangements, which is why we've got the medication-assisted treatment outcomes now that the country, Scotland, is wrestling with, let's say, at the moment. Staffing, massive staffing and workforce issues in this area. Unsurprisingly, people are paid more at local Safeways and Waitrose or Sainsbury's than working in homelessness services. Poor levels of staffing, let's say. I'm not blaming staff here at all, but there can be poor levels of training, poor levels of supervision and support. High staff turnover, the high caseloads we heard from Dame Carol Black today, judgmental attitudes, though I have to say, can be endemic, and these can be re-traumatizing for people who use services. The length of treatment for treatments for substance use is also a major problem. They can be very, very short-term, massive lack of aftercare, and particularly women in studies talk about these issues. Particularly the lack of aftercare. It's if you do get into residential treatment, for example, that's it. There's nothing when you come out. There's something that the task force and the Scottish Government are now working on, but that's a long-term mission, I must say, for the national mission. Healthcare costs, I must say, just because we have the NHS here doesn't mean everybody has an NHS. So insurance and costs can be major barriers. In terms of engagement with healthcare, for people with intersecting multiple exclusion, homelessness and related issues, they often use A&E rather than primary care, partly because there isn't primary care available to them, but often because it's what's available to them because they're working on their survival needs, but also due to a mistrust of services. People, for all the reasons I've just spoken about, often don't want to go back into either mental health, substance use or homelessness services. They don't feel safe there or welcome there, and they're re-traumatizing. This list is not exhaustive. I don't have as much time as I'd have liked, and there are specific barriers for some groups. Rose has talked about some of them, but I don't have time to go into them in more detail, other than to say I'll just spend a little bit of time. People from global majority communities are likely to report additional barriers to finding treatment that works for them, including racism and stigma, a lack of understanding of their culture, in addition to the risks we were hearing from Niamh and others around over-policing and criminalisation. So, what to do next? So what's the what? Specific types of interventions, again, I'm going to rattle through these, 4 minutes left. I'd like to say that the evidence base is really clear on these things. We've done a number of reviews, and it's actually not straightforward. It's a complex field, and each of the interventions that I put here have caveats. For example, Molodina and colleagues published a systematic review, 156 pages of it, last year on interventions to improve the health and well-being of people who experience homelessness. That review showed that permanent social housing has significant benefits on housing stability, but strangely these benefits didn't extend to improvement of mental health or substance use outcomes. So some really strange findings when you dig deep, and these are difficult to figure out. But no surprises within much of this has been spoken about at the conference. And again, what to say about interventions at the end there, the needs of women, global majority community members, people who identify as LGBT+, are often ignored in research. You won't even get mention. And this is a difficulty when you're trying to pull together these sort of high-level lists of what works. It's about what works for who and when, quite often. So I've got some visuals here. This is a painting that was created as a part of our study that our team ran on the potential of managed alcohol programs, maps for people experiencing homelessness in Scotland during the COVID-19 pandemic. The artist is Linda McGowan, who lives here in Glasgow, and she did about 10 paintings, was it, for this project, partly because it was a virtual project and we wanted to bring the data alive. So she was a member of our research team who made the paintings as she heard the data and spoke to the staff members and the team. It illustrates the outreach to people who were street homeless during the pandemic in Scotland and taking care, such as opioid agonist treatment, out to people where they were on the streets rather than expecting them to come into services. For example, going out and actually finding people in graveyards and sleeping rough during the pandemic. In Scotland, many people who experience homelessness and are alcohol dependent are also using drugs, including toxic street drugs. So while MAPS might well be an intervention that we should have in Scotland for alcohol dependency, they have the potential to deal with many of the issues that I've spoken about today through provision of safer housing, connecting people into wider services such as needle exchange and overdose prevention. Here in Scotland, benzos are cheaper than alcohol, so we can't just put people into even alcohol or drugs. The integration that Dame Carol spoke about this morning has to be across alcohol and drugs as well as substance use and mental health, as another of the paintings. And that's Linda. Effective interventions, the how, let's turn to that, how they should be delivered. So we did a meta-ethnography a few years ago. Hannah is the lead author on this. I was merely supporting. In this, a meta-ethnography synthesized qualitative studies. And this was a study that we published, which was from the perspective of people who are homeless themselves. It's their point of view. The findings highlight, this is the model here, and the writing is just what you can't see in the green because the text is quite small. Findings highlight that people, the treatment that people receive, the substance use treatment that they received needed to be safe. if it was to be effective, that we needed to be service environments that facilitated safety. They needed and wanted compassionate and non-judgmental support. They wanted time, choices, again, and opportunities to relearn how to live. And again, the point about longer duration and the stability that a longer duration aftercare provided was absolutely a key finding in this. So the takeaway message from this study was that the way that services and treatment are delivered was more important than the what was developed, that was more important than the what was developed. Good relationships, we've heard about this whole conference, person-centered care, and understanding the complexity of people's lives. Very briefly, because it's going to be covered next, way better than this, I'm sure, we did a study about the provision of peer support at the intersection of homelessness and problem substance use services. It was a state-of-the-art review. It really just showed us that whilst a lot of work is around now on peer support, there's significant variation, and the challenges faced by peers were identified: vulnerability, authenticity, boundaries, stigma, and a lack of recognition, and we developed a bit of guidance on that. So, Wes is in the audience, he's going to hate me for this. I'm going to end, I've only got a minute here, by just talking about our complex intervention that we co-developed with people with lived experience. It was funded by the NIHR, National Institutes for Health Research, and was a collaboration between the University of Stirling, Aberdeen, University of Victoria in British Columbia, NHS Lothian and Scottish Drugs Forum. SHARPS is its acronym, and it stands for Supporting Harm Reduction Through Peer Support. It examined a peer-developed relational harm reduction intervention, which was delivered by these 4 peer navigators who worked across third sector residential and outreach services in England and Scotland. They had small caseloads of 15 people. We co-developed the intervention, as I said, and used a trauma-informed, psychologically informed environment approach. All the peer navigators had experience, relevant lived experience, and they were paid as specialist workers because they are specialist workers. All the issues with their participants, as we called them, the client service users, have been discussed today already in terms of physical health problems like asthma, dental problems, chronic pain, back problems. They all had at least one diagnosed health condition. Many had anxiety and depression. So I'm just going to finish with a few quotes. SHARPS provided, as in the purple, what they provided, person-centered intensive support. And I'll just leave you to have a wee look at the quote there. They were brokers, they were spanners between statutory services and non-profit services and mutual aid services for people. They created the flexibility so that the participant themselves could self-direct their goals and decide which way to help. They needed help to fulfill these. The navigators were able to move freely with the participants. They were like case managers, but they were able to be directed by the people that they were working with, negotiating barriers at multiple levels, such as attempting to balance an individual's challenging life circumstances with the service's inflexibility regarding their appointment times. In terms of implications for the services, other service more generally, achieving these outcomes takes time, persistence, role flexibility, and sticky support, as the navigators talked about. I've just got another half a minute. Our study was a place for lived experience. The navigators we talked about as magnets that pulled people towards them. These are some of the, Wes is going to laugh here, these are some of the roles, the many roles that the peer navigators undertook, including being asked to be guarantors for loans, which they had to draw a line under. Finally, they created networks and connections. I just leave this quote up, but they built relationships. They helped people to develop their own relationships by being advocates and walking with. It's my last slide now. Thank you. Linda's final painting here. Overall, the lived experience of the peer navigators was highlighted in our final study report as particularly helpful in creating positive outcomes for people. Why did it have to end, though? You know, it was the ethics, very difficult, challenging ethics around doing a study like this. that had to finish. However, we're delighted that we've been provisionally funded for a next stage trial, but don't tell anybody because, as I said, it's only provisional funding at the moment. But the idea is you have to build the evidence step by step. The next stage will be a randomised control trial, and we're going to make sure that Wes and Josh and Michael and Becky are involved in that. So to finish, I talked about the intersections of multiple exclusion homelessness with a range of harms, including premature death, increased risk of HIV and hepatitis acquisition, and describe many of the, or most of the, or some of the barriers to care for this group of people. I've talked about one complex intervention, but there are many more that you'll be aware of that we need to support. I'd like to finally thank our centre staff and funders, our people with lived experience, affected family members, to Linda, our amazing artist in residence, and to Hannah Carver, who helped me with my slides.
Okay, so we're on to our final speaker, who is Royk. Apologies if I have pronounced your name wrong, so please correct me. She's a social anthropologist with a master's degree in criminology and sociology of the penal system. She founded Metzinaires, a non-profit cooperative that provides environments of shelter for women and gender-diverse people who use drugs who are surviving violence. She's also an international advisor on gender-based harm reduction approaches.
Thank you so much. And thank you for being here at this time. First of all, because Metzinaires is a really difficult word, comes from the Old Catalan, and were these women that were burned because they were witches that use plants as a remedy or as a poison. I like to say that when we talk about the war on drugs, we normally are thinking about the end of the 19th century or the beginning of the 20th century. But for women, the war on drugs began really earlier. Like, we were using plants or drugs for our wellness, for our pleasure, for the pain of our communities, in this more communitarian perspective of what health and wellness means. Let's came the church, the Inquisition, and they just told this right to us to give it to the doctor that used to be a high-class man that normally take care about or understands health as the lack of pain, not as the wellness. As you can see, the plants that these women were using are the same plants that are now in the base of the modern pharmacology. The only way is that we don't have the right to know it. The knowledge that was popular and was a communitarian knowledge that the women hold now are in the same hands of the pharmacists and the doctors. This is, also I want to do another parenthesis. I want to say that the stigma that began in the Middle Ages is still the same stigma that women who use drugs and gender non-conforming people who use drugs is still facing every day. Also, I want to do another parenthesis about the drug policy in Catalonia. And I am saying Catalonia not because I am independentist, and maybe, but because Catalonia had a really different perspective than Spain. In Catalonia, at the beginning of the 90s, they really engaged in harm reduction. We have had consumption rooms, cannabis social clubs, drug checking services for around 30 years now. And they work because we were one of the cities with the higher rates of HIV, and that's because overdose now is not that way. But I have to say that 30 years later, we have the people surviving but not living. Like, we have chronifying the exclusion of the people that is using drugs. And yeah, and especially when we talk about women. But not just, like, we have these amazing services, but we have segmentarized the people. Like if you are homeless, you have to go there. If you use drugs, you have to go there. If you have mental health issues, you have to go to the other way. And everybody's giving you this kind of contradictory things that you have to do because they know better than you what you need, and nobody is looking at each other in their whole, as a person, no? As a whole person. Then what we saw specifically in women was that they were going to the drug services. They were not feeling safe. They just represent around 15%. And when I am talking about women, I am talking about non-binary people. Sorry, it's because that we used to use the X. You will see our posters saying like women take drugs. We have some of them here if you want. Then we use the X just to make sure that we are not talking just about cis women, but also about non-binary gender people and trans women. They go to these drug services and they don't feel safe. I don't want to repeat myself because my colleague did it before. When they go to a specific services, for example, for women surviving violence, they are not accepted there or they are expelled because they are using drugs. Then finally what we are finding is that we have a really lack of alternatives and also that are incrementing the social injustice and the systematic vulnerability of their rights, making worse this chronification of the situation. It's because that we create Medicineras, that is the first non-profit cooperative that we have in Spain. We don't like to define ourselves as a consumption room because we don't just do consumption room. When we see that if we want to accept women in their complexity, we need to include the drug use inside of the necessities. And the women can come there, they can use drugs, they can use whatever drug they want. They can use alcohol, whatever. They can inject, they can smoke, they can snort. But when you take away the drugs as a barrier, you can see that is really the complexity and the intersectionality. But I'm spoiling myself then. We did that, we opened that, talking about human rights. We are not doing assistantialism, we are doing activism. We want to go to structural causes of inequality, and this is, for example, the war on drugs, but also the male chauvinist, the patriarchy, the social inequality, the social injustice. We want to do it that really, like, we didn't want that the women had to go any other place to be referred to our places, then they come and they can enter. We didn't introduce also ourselves as a service for women. We are part of the community, we are neighbors, we live in the neighborhood. Like we sleep there, we work there, then who is more neighborhood? Who can rent a house there, or the people that is spending all the day there and being part of the community? And we do that, like, for sure, like, also in Barcelona we have these amazing social movements and solidarity-based economy, then we wanted to be part of that, of course. These are the principles that guide Medicineras. We had to be really creative because we see that the normalized or the standardized services are not working for us. Radical alternatives, nobody can be barred from Medicineras. Everybody, like, doesn't matter if a friend comes and throws something to us, she's gonna be welcome tomorrow. Maybe not today, but tomorrow she will. Like, resilience is not something that we do individually, it's collective, and we are stronger together. With Royk courages, we are living in a place where harm reduction is totally institutionalized, it's not revolutionary at all, and doesn't go to the structural causes of inequality. Then we need to recover the activism inside harm reduction. We are not talking about health, also we are, but not just. We are talking about changing the world. This is because that we include the activism in the care, complicity, and we do that in the complicity and mutual support. I don't like the word peer, and I don't like the word peer because when we are talking about intersectionality, who is peer and who is not, no? Because everybody can be around, and we are changing positions all the time, no? And also because some of the peers have been like just handling needles for 30 years because they cannot evolve in their position or whatever, no? Then let's change a little bit that. Anti-prohibition is commitment, because this is one of the causes of the stigma and the inequality and the lack of access to the services, the prohibitionism. Then we need to change the law. And we are not inventing the wheel. We were really inspired for the work made around the world, especially the work done in Canada. Thank you for yesterday, it was amazing, about the DALF initiative and Bandu and Euromput and all the activists that are really passionate about work and transformative passion. You can see that. Like medicineras, when you take away the drugs, you can see that what the women that are part of medicineras have a lot of different problems that are not just how they relate with drugs. In fact, they use drugs to survive most of these other situations, no? Like 86% don't have a safe place to sleep. Around 70% are sleeping directly in the streets. A lot of them have been in prison. All of them have been criminalized, that for sure. They are facing mental health diagnosis, 30% racialized, around 40% are part of the LGBT community. When we began, they were saying us that we will have like around 40 women. We have 370 women now, and every day comes more women. As you can see, like they use a lot of different drugs. One of the things that I want to say here is that it is not related if it's legal or not to have problems or not. And one of the things is that they use cannabis as a tool of harm reduction. We have that if you want to read it, and we can talk a little bit later if you are interested in how they use cannabis as a tool of harm reduction. And they survive a lot of different situations of violence. They are overrepresented in violence during the childhood, during the adulthood, because the criminalization, because the exclusion of social and health care. They are survivors. What we do, we put the person in the center. Each one has the freedom to decide what is their path, what they want to do, and we need to be helpful for our friends, always looking at the empowerment, the autonomy, and the well-being of each one. We try to reduce barriers and help to navigate through the standardized service and networks. We support them to they are part of, for sure, women with life experience are experts of our community. Then we don't talk about peers, we talk about community technicians. Sorry, my English is going worse. But because they are the real experts in the community, and they arrive where a lot of staff members or other staff members cannot arrive. Like the lawyer doesn't gonna go to a shooting gallery, but most of the women are going every day. They are bringing the facilities that we can there, no? But also we are trying to make sure that we are part of all the politics and plans that gonna condition their lives. And we love to go to the streets. Like, we love demonstrations. Then we go there to fight against the war on drugs, to fight against patriarchy, to fight against, like, just whatever. Like, we had this colonizing party past week, like, you know, like, we discover America, whatever. Then we also go there. What we do is like, we are like a double garage. We are not a huge place, but we have beds, we have the basic needs, we have social worker, a lawyer, like nurses. But also what we are trying is that all the time something is going on, like workshop, theater, music, We go to a lot of cultural activities. Also, we do a lot of different things. Like we have like merchandising, and we go to the market to try to sell them. We are like really bad on business. We don't make money, but we try. Then we go there, and yeah, you can see production and entrepreneur, whatever it means. And I am going so fast because I want to show you the video that they made. And they are really creative, then we are trying to support with arts and creativity. And the most famous activity that we do is that every Friday we prepare a paella for all the neighbors. And they love us, of course. And to show that, I want to show you the video that they did.
Somos consumidoras, pero aunque seamos consumidoras, no dejamos de ser personas. Nos podemos relacionar, podemos trabajar, podemos tener hijos, podemos tener amantes, podemos tener maridos, podemos poner en una casa, puedo fregar platos y puedo tomar droga.
Hola, ¿os puedo hacer una pregunta, por favor? ¿Cómo es el trato con la gente que consume droga, la percepción que tenéis ahora? Era que teníais anteriormente, claro.
Ha sido radicalmente diferente, sí, de alguien que no conocíamos de nada hasta saber los nombres, ¿no?
Reconocernos, bromear, ser vecinas también, ¿no? Y compartir relajadamente un espacio que no nos imaginábamos antes.
Hola Carmen, ¿cómo ha cambiado la opinión de las vecinas desde que se hacen proyectos en conjunto con vecineras?
Yo creo que es muy positivo. Ahora he tenido la oportunidad de poder estar más cerca de vosotras y aún más veo que los resultados son maravillosos, ¿no? Este confinamiento ha sido muy potente para ver cómo funcionáis y cómo colaboráis entre vosotras y cómo colaboran las vecinas con vosotras, y creo que ha sido maravilloso, ¿no? Entonces, más no puedo decir, estoy encantada con vosotras.
Nosotras estamos encantadas con la mano que tiene Carmen para cocinar, que nos ha aportado ricas comidas y ricos postres. Gracias, Carmen.
¿Cómo ha sido la llegada de medicineras al barrio con su trabajo comunitario?
Pues mira, yo al principio no sabía muy bien, no lo conocía, cuál era el trabajo que hacían, pero yo creo que es fundamental para las mujeres que usan drogas tener un sitio donde se les acoja, se les cuide, se les mime, la pueda ver el médico. Mesinera ha hecho visible que la gente que usa drogas son gente tan normal como cualquiera, con un problema como cualquiera tiene el suyo. Y que bueno, que lo menos que podemos hacer es apoyarla y darle visibilidad. Yo ahora no veo una drogadicta, veo a Susana, a todas por su nombre, porque las conocemos. Y bueno, a mí me parece que eso ya es un gran cambio.
Gracias por responder.
Dice así, supe construir un lugar donde vivir, así que nadie me va a convencer de que me tengo que ir. No me voy a ir, esta es mi casa. Ven y pasa, miremos desde la terraza. Cuando te miro todo se me pasa. No hay nada contra la fuerza de nuestra raza. Yo te convido si te falta, a mí me sobra mucha
Corte, ¿qué opinas sobre Metserel?
Pues que sois un grupo muy alegre, que hacéis cosas muy interesantes, muy buenas para el barrio, para el mundo. Para mí lo importante es que las personas consumidoras o no en general sean dueñas de su cuerpo, de su vida y sobre todo que tengan salud.
¿Y cómo cambia el barrio desde que Metserelas aparece por aquí, por el Ágora?
Cuando entra un colectivo como Metsineras en estos espacios, entramos en contacto personas que igual de otra manera es más difícil. Porque hay prejuicio, porque tenemos miedo, porque no conocemos al otro o a la otra. Y entonces cuesta mucho relacionarte. Y este espacio es fantástico para que nos conozcamos, para que haya esa mirada de ida y de vuelta. Y es fantástico.
Señores y señoras, para mayores de 18 años, rico, fácil, para toda la familia. Rico vecinaje, Noa al micro.
Hola, ¿qué tal? ¿Cómo está todo, guapa? ¡Ay, no! Soy Luana Monteiro, soy reportera
de Messinera. Estamos aquí en el barrio de Raval para ver cómo los vecinos aceptan la entrada a un nuevo grupo llamado Messineras.
Me parece un espacio súper bonito y súper necesario en el barrio, porque es una realidad que existe. Son situaciones que te podrían pasar a ti.
¿Qué te gustó más de todo?
Hostia, la energía que hay, el buen rollismo, la sanidad que hay entre vosotras, la sororidad que hay entre vosotras y cómo os cuidáis y cómo os tenéis presentes, teniendo en cuenta que seguramente hay momentos que no habéis estado de todo bien, pero oye...
Nos hemos sentido súper cómodas aquí haciendo un evento con vosotras y haciendo un montón de cosas, que es una forma también de interseccionar muchas luchas, ¿no? O sea, contra la transfobia, anticapitalista, antifeminista, contra el estigma de las drogas y que al final sí estamos todas en la misma lucha.
En el momento que nosotros entramos aquí, había un poco de estigma. Se consumían drogas, se no consumía drogas, ¿qué íbamos a hacer? Cosas así, ¿no?
Sí, bueno, porque de hecho así de primeras a la gente es algo que le tira para atrás. Asocia el consumo de drogas con mala gente. No es así, ¿no? Ya lo demostráis vosotras. Vuestra presencia aquí pues ha hecho que mucha gente pues vea el consumo de drogas de otra manera.
Yo creo que esto tienen que ser ensayos para una futura sociedad realmente libre, donde establezcamos un tipo de relaciones humanas, solidarias, libres, de mucho respeto de todos los unos con los otros y las otras, y de saber arrimar el hombro cuando cualquiera lo necesite.
No se olviden, beber también es droga, fumar también es droga, somos todos iguales y todos vamos a morir igual, ¿vale? No se olviden.
Que nadie quede afuera, debería ser un decreto. Le saco la careta a este gobierno y su secreto. No quiero más policía.
If you want to know more, you can visit us, and we have amazing t-shirts.
That's fantastic. That's just fantastic. Just a couple of quick housekeeping items, then we got about 18 minutes for questions. Exhibition hall will be closing at 4:30, and no one will be allowed access unless you're an exhibitor. So just remove anything you have, including posters you'd like to keep by 4:20. And everyone has access to the virtual portal. If you missed any talks. And then maybe it might be easiest, I think we got enough chairs, if the three presenters, if you want to come up, and then we can just open it up for questions.
Should I go for it? Yeah. Firstly, thank you very much to all the speakers. I thought all three talks were amazing, and especially the video at the end. I thought that was really fantastic. So my question's actually for Dr. Parks. So alongside, I'm a PhD student, but alongside I'm an outreach worker for St. Mungo's. And before that, I worked in shelters and Housing First and a few different areas of homelessness services. And just as an example, in outreach, we're kind of trained to, in our first encounter with someone on the street when they're rough sleeping, is to immediately try and understand their substance use. And the assessment focuses in on substance use, often before it focuses in on housing history or family relations or potentially other things that could be or influencing their reason for being on the street. And I feel like a lot of the time, staff are trained to be quite kind of condescending and paternalistic in the way that they speak, especially in outreach work. And that's a huge problem that I've seen both in Canada and also in the UK working in these services. And I was just wondering if, with your research, you've had the opportunity to engage with homelessness services as a means of doing staff training around how actually the way that substance use is looked at within homelessness services is very stigmatizing in itself and really doesn't get to the root causes of rough sleeping.
Thank you very much. Wow, that was a big question. Wes, do you want to say, would you like to though? Because you do the work and I just talk about it. Would that be okay? Yeah, perfect.
Yeah, that's absolutely fine. I'll just give my tuppence worth, I guess, as a kind of lone practitioner that was afforded the privilege of a really autonomous role, of a relational intervention. And I think the key, and I think fundamentally in a lot of our commissioned services and even non-commissioned services, we're outcome focused. And the outcome is not on the relationship. The outcome is on the substance use, it's on the access to benefits, it's on the access to healthcare, whatever your outcome is kind of based on. So, I mean, my own personal experience of being on the street and using problematically, we're very, very savvy. You're bringing an agenda into that first interaction straight away. So I know you've got an agenda. And even though you might be quite good at building that relationship, you've brought an agenda to that relationship before even just connecting. So one human connecting to another, then building from that. And I'd love to see a world where more services are just about building that relationship and seeing where the person wants to take it. And, you know, you need quite a big skill mix, or I used to see my role as being a buffer between a person and a service they need, but I've got to connect with the person first. They're not going to trust me to take them to any service that may or may not have mistreated them in the past until they've got that foundation and that kind of trust with me. Very difficult to do. I don't know how commissioners would be able to fund services like that because they want numbers, they want outcomes, they want evidence. Let's call a relationship an evidence. You know, I think any form of relationship is harm reduction. Any healthy relationship that people have often not had for decades, if ever, in their life sometimes. So yeah, that's just my tuppence worth on that.
Keep doing the work that you're doing, and you yourself will be the change in the service that you want to see, yeah? You know, we all have to put those outcomes to the side. Even, I mean, doing research, you know, we had to pitch an intervention because that's what the funder wanted. NIHSU wanted an intervention. And we looked at all the research around homelessness and substance use, and it kept pointing us to don't have the agenda, build the relationship. So we dared to suggest that to the funder, but they've gone with it. And the tricky next step will be how we do a trial. We're not randomizing people, by the way, we're randomizing the services. But it's still, it's difficult because we are invested in, and I get the definition terminology, and peer is not, it's not there, right? But when we were pitching the intervention, it was as close as we could get. We were looking to the Canadian model, where peers meant Van Du and all the work that they were doing to humanize services. So I just wanted to say that about terminology, but and training actually for the peers, like Wes, like the magnets. It was light training because it was like we also didn't want to train out what we just heard Wes saying. So they were specialist experts when they came in the door to the interviews. So yeah, you have to balance that, but also helping people get the confidence that Wes speaks with now, but maybe, you know, to develop that sense of knowing what was best, which was helping people. And just the other thing to say is nobody was excluded from the trial for either not using or using any substance, so there was no exclusion either.
Great, amazing panel presentation. I truly enjoyed it. I think it's the most I enjoy in the conference. So thank you. I have a question. I work in New York, Pedro Mateo CUNY School of Public Health. One thing we are noticing among young people who use these drugs is that there is very limited access to sexual reproductive health for people who use drugs. And I'm struck by the absence of that topic in the conference, and also intrigued by what are your thoughts on is that a misperception? Is that something that is readily available to the woman who uses drugs? And B, how can we do that better? Thank you.
It's a good question. I think it's really service dependent.
You know, I would say that there are some services that do a really good job integrating that, and I think that there's some that, particularly that are gender blind services, that have no consideration of that. I think it is really important. I think once you sort of enter pregnancy and parenting into a relationship of a person's substance use, it adds a whole level of complexity. And you know, I don't know about other places, but Canada, it's something like 56% of all pregnancies are unplanned. So I think in terms of choice and autonomy, I think it's you're right. I think it is really crucial to integrate into services. Don't really have much more.
Yeah, I just want to add that I don't know for you, but most of the harm reduction services are really not attractive at all. Like, and I understand that you don't want to do a disco there or whatever, but they just are focused really on drug problems in a really medicalized way. Then young people doesn't gonna go there. Then I think that we need to talk with their language. We need to have young people working there that they can feel engaged and they can address their needs. If you go there and you can find that you don't feel identified with anybody that is there, it's really difficult that you gonna accept any kind of support.
I'll ask you guys a question. I don't know if this is on. So you talked a lot of focuses on women. So in my province, Saskatchewan, Canada, do a lot of work with Indigenous populations, and we see women overrepresented in all STBBIs, endocarditis, mortality, overdose, and it's a lot related to the vulnerability, sex for drugs, sex trade work, gangs. Oftentimes, the only time they can actually get into care or engage, just due to the power dynamics, is during pregnancy. And that's often the only time we get a chance, or there's an opportunity to engage them in care. What interventions or what do you see could help? Because that's maybe the only time you actually, they actually can get into care, or they feel like safe going. What are your thoughts on that?
I have a lot of thoughts on this. It's my primary area of research, actually. I think that, you know, my life goal, my research goal is to get the message to service providers and service designers that we just need to stop treating women like shit when they come to services, when they're pregnant, and stop, stop, they become just a baby vessel at a certain point, right? Because it's like, it's not actually, the only reason that they have an opportunity to seek services then is because they are carrying a future child. And there's a pressure put on services and women, people who can get pregnant, to have this healthy child. And it's not really about caring for the person who uses drugs at that time. And I think that if we think of sort of the mom-baby dyad, even as a start, to think that, you know, it's not just a pregnant person, it is a person who had this whole complex life. They had this violence, perhaps, they had maybe this controlling relationship, they have substance use, they have all these other things. And not treating people like such crap, you know, like for using drugs during pregnancy. There are plenty of great parents who use drugs, and there's plenty of, you know, opioids are not teratogenic. They don't cause birth defects. With proper care, nutrition, and treatment, they don't lead to lasting outcomes for babies. So, yeah, I think that we need to radically change the way we work with people. Your presentation was amazing. I totally agree that radical empathy or something like that. I like that a lot. And I think that, because you're right, it is that sort of that little window. There's a little bit of funding, there's a little bit of priority spacing, and people will not engage with services if they're treated like crap and their babies are taken away.
I want to say two things. Women don't go to the services and they don't ask help because there are no help that is accurate for them. Then I was saying that when we began, they were saying, no, there are no women there. You're just going to have like around 40 women. We have like 370 women, and every day new women are coming. Then they are there when you put services that are useful for them. And they're going to come and they're going to ask for support, or they're gonna find the support with you provide that, for sure, or where they have access to that. This is one. And the other one is like, of course, if you give support from the beginning to the women that are pregnant, the possibilities to have a successful motherhood are amazing, that they want the best for their children. No? And one of the things is that, and I want to correct myself, because in one of the slides, we say that women who lost custody. This is not true. Like normally, women give away the custody to their kids, to family members, whatever, because they want to have the best care for their kids. And when they see themselves not being to provide this care, they ask for support. Then if we can, or whoever needs to do that, like, can give resources to develop these services from the beginning. They don't have to go to different places, that they don't feel judged, and they don't have the risk to lose their custody. They used to be really, really, really successful. In our case, we have the obligation, if a pregnant woman comes to our service, we had the obligation to say the police that, or not the police, the child. Yeah, thank you. We don't do that, but we should.
Hi, my name's Matt Smith. I'm a researcher here in Glasgow. I've just noticed a kind of thread through a lot of the presentations talking about patient-centered, people-centered care, but also trauma-informed care, and Rosie mentioned that as well as being an area of your specialty. But I just wonder what you all think about where that is in terms of going mainstream in Canada and in Catalonia and Scotland, the idea of trauma-informed care.
Trauma-informed care, like gender, is one of those things that I think if it's not on the table all the time, people forget about it. One of the things I like about trauma-informed care is that it asks us as service providers why people aren't accessing services and why services are failing, and not the other way around. So it's acknowledging that it's not about sort of lack of adherence or things like that. It's like our services don't meet the needs of people. I think that there's some really great examples of trauma-informed services in Canada. Jean Tweed is a great one. But I would say most services aren't. I think it's, for the most part, it's only women's services that ever really do it. I also think that trauma-informed practice, trauma-informed care is what they call it in the United States, risks reducing everything to trauma to some extent, and has a potential to pathologize very common experiences. So for example, in the United States, trauma-informed care often starts with a screening for trauma, like those ACEs tests, like, were you abused as a child? And that's not a great way to start a relationship. So assuming a universal precaution like hand washing, assume that people probably have had a bad experience, and you can treat everyone the same, with choice and collaboration and trustworthiness and skill building and et cetera, would lead to better outcomes.
Tina, I'm a nurse from Ontario, and we have a harm reduction site that I also am a peer at. But there's no community connected to it. It's just you use and you leave. So our relations with our community partners are quite weak because, people are wandering the streets, obviously intoxicated. And so it was nice to see those ideas, because I think a community, because I know I heal in community. And I think community is important, and it's nice to have a space to go and not hide. So I wanted to say that. And I also didn't know there was, that women suffered. As a woman, myself, I didn't know until I started. I was 10 years oncology nurse before I came into this job. And, there's just, they come in with their partners, and there's a look, and it's usually they look to the ground, they look at me, and they look at the door, and I know they want to talk to me, but not there. And I've done a lot of meeting at my car so they can tell me what's going on out of earshot. They don't even want to go into my room because they don't want people to say, oh, she's seeing the nurse. She probably has syphilis, right? So I've learned to work within those parameters for privacy reasons because especially if your income is tied to things at a consumption site, that there's too much talk for some people, right? And other people, it's a great place to go. But I've noticed that. So I guess I don't really have a question. I was really excited to see the community involved in all the work that's being done. You know, a bar is a consumption site. Yeah. It is in Ontario. And also just the fact that there is no childcare in a hospital for the majority of workers are women shows that there is a difference in the sexes and the gender roles that we fill. So thank you very much.
I was so excited to see what your service looked like and to see that service, because I presented a picture at the beginning, right, of Sister Space, the best thing we've got, and I was like, oh look, it's like a non-medicalized environment, and compared to what yours looks like, it looked like it looked like a health clinic. Yeah. So I think that the idea that, like, you're right, a bar is a safe consumption site, and you get to hang out and talk, and you know, we use drugs and alcohol for lots of reasons: relax, have fun, enjoy them. So you don't really do that in a sterile desk.
And I want to say that one of the biggest issues when you are talking about trauma-centered is to have a safe place to stay. Like, women that are in the streets have their life is 24 hours alive. Like, you can see where they pee, where they take a shower. They cannot have a chat with their friends in an intimate way. Then just to have a place where you can stay with your own rhythm, with no one saying like, oh, you should do that, you should do the other thing. Can you clean your hands? Can you do blah, blah, blah. You know, like, you want to be free for a while, and to be free and to have an intimate place is important. That this is the first thing. When they come to our place, we don't have any kind of interview. I'm anthropologist, you know, like we go there, we have a lot of conversations, and after that we go to the computer, and we really spend a lot of time in front of the computer systematizing this information, because I don't want that my coworkers go there and ask the same fucking questions again and again because she wasn't not there. Or then we systematize this information, but we don't do that like with a questionnaire. We do that with a coffee or with a beer, you know, like, or with a joint. Yeah, right. Then we can do that, we can spend that time and build this kind of safety in the community also, not just in our places, closed doors, like also in the community is a way to be trauma-centered proposal.
And safety can be established in such simple ways, like offering someone if they'd like a glass of water when they come into a service, or like not having a giant plexiglass barrier between you and the harmful substance user.
Yeah.
Right?
We're just 2 minutes over past 4, so I just want to thank everybody for coming, and to our 3 fabulous speakers. And now I think it's tea and coffee break. Thanks.